challenges on the 9th level essentially were time. The time restraints, the time we have with staff. Communication is key to measuring and monitoring safety. It's the ability to repeat, talk about this on a frequent basis. And when you're dealing with shift workers, you don't get that much time to spend with them. So the time you do have, you have to spend talking. You have to spend a significant amount of time just to get the message across. And for many people, and many nurses, they're senior or seasoned nurses. They've spent a lot of time doing multiple initiatives. So now they're at the point, they're like, is this the newest one rolling through, and when's the next one gonna come through? So it took a significant amount of time before this took hold. And we needed to make sure that it wasn't just another project. We needed to integrate it into the work they were doing. So it wasn't another tick box exercise. It wasn't just another initiative to roll through to say we've completed. So once they realized this was taking hold and it was now a part of their everyday work, that's when we were able to actually roll out other projects using this framework. The framework in and of itself wasn't the project. So the successes that worked very well were our huddle. Our huddle was the communication tool that we used. It was the time we got daily to speak with the staff, and it was the time the staff got to talk to the manager, talk to the clinical educator, talk to the resource nurse. And there are 2 units, so we run them at the exact same time so that the units got to talk to one another too to see what's going on. So that's when we started to see, are there systems issues that are in play that we need to be readdressed? Are there in the moment safety concerns with specific patients or family members that need to be addressed? Are there tools to do your job that need to be addressed because they can't actually be nurses today because they're missing 4 vital signs machines that no one identified properly, even though there is a system in place to do that. So once we had all of that running, that was where we were most successful.
The focus tended to be about past harm, and we were heavily engaged in quality of care reviews and patient safety incidents. However, this measuring and monitoring for patient safety, the 5 dimensions, broaden our thinking perspective in terms of we need to look at other dimensions about reliability, anticipation and preparedness, integration and learning, and sensitivity to operations. And so we didn't try to create a new initiative or a new project. We looked at what was going to happen and how can this framework piggyback on that. So one example I would like to give is the executive patient safety round. So I perceived it as a sensitivity to operations where senior leaders, vice president and above, are going on a weekly basis and talking to the staff about their and patient safety. So that's about being sensitive to operations. However, the questions have been framed which are addressing the other dimensions. For example, do you anticipate any barriers, or do you have any concerns in the coming few days in terms of patient safety? That is actually drilling down and inquiring about anticipation and preparedness. So that's what the approach has been to identify initiatives that are happening. The other is an integrated huddle board. So yes, it was being piloted in lessons unit, but how we can standardize and integrate it, these are part of that standardization. So it's going to be digital, and it will be launched across all 3 sites. The pilot has shown very positive effects. So that's how we are learning to spread this without making it an explicit new initiative or new framework.
So my favorite example for the team level of how they utilize measuring and monitoring safety actually is just, it wasn't even a project, it was a conversation that was had. And in many instances, when you come in on a Monday morning, you just want to get in and get your day started and find out what occurred over the weekend. Where I was bombarded, that's a good word, bombarded with staff coming to visit. The staff have been sitting around over the weekend coming up with a list of safety concerns that they had, and we wanted to talk to you about them. I know many managers may want to not deal with that right now, but to me that was a great thing, and they were just coming with problems, they had solutions. And we were having a conversation later at the huddle on how they actually would actually be put into the dimensions of the framework. So we had a few issues that were clearly reliability issues in terms of some housekeeping issues, and there was an increased mess over the weekend. So I was able to talk with their manager, and we came up with a clear plan on how that was going to be dealt with. There was some sensitivity to operations around a workplace violence issue that had occurred, and there's some suggestions that came forward from that, and they were all addressed. So from team level, the team's now talking about safety, not just at the 15-minute huddle, but on a daily basis with one another when I'm not even there. So that's amazing that they're actually doing this on their own now. So at an institutional level, we started small. So we actually have EGH Clinical Operations, which is a meeting of medicine managers, the educator, the lead hospitalists, the resource nurses, and we invite other guests to come in as well from Access and Flow, from the transition care coordinators, to talk about how our operations are going at EGH medicine in general. So they became aware of clinical operations and MMS at ClinOps. And we began talking about some of the safety initiatives that we're doing, how we were rolling them out, how the huddle was becoming very, very effective. Dr. Karen Dang, who isn't with us today, is also one of our team members, talked about coming to our huddles, and she came to our huddles for almost a week to talk about the physician perspective of safety. So it grew from there to a much bigger kind of initiative, and we started utilizing the huddles. We designed our own new huddle board in consultation with Virginia, with everyone on the team, to actually design our own huddle board, so how it would help the team have the conversation. Again, the huddle board isn't a project, it's the tool to talk about the projects. So from there, we didn't just want to do a one and done. We were constantly PDSing our huddle boards, and we came up with a new one that was launched across the organization, which was a metallic board, which we worked with the strategy team on as well to have all of our key metrics in place. We're about to go through an accreditation cycle as well, so we're talking about all of those metrics. It's all integrated together. If we're safe, giving safe care, that's what healthcare is supposed to be about. So, and from there, we realized one of the biggest challenges was identifying the daily themes. Yes, we could talk about our were we safe today, will we be safe in the future, but 2 weeks later, the nurses won't have that cross-site view of everything that's happened over the past month. Using a digital board now, we'll be able to show the trends. We'll be able to talk about the initiatives that we've put in place and how they've affected the trends. So I think that'll bring our team all the way back to the safety concerns that they've raised, the ideas they've brought forward, and now they'll be able to see what the impact is on actual data.
So the leadership is quite involved in this. And also there's one more key factor is the trust between the operational leads and the senior leadership. We are able to take decisions. As long as we keep them informed, we take decisions rather than waiting for an approval, and that helps this process move much forward. And we have monthly meetings with them, so they know what's happening, but we will take decisions and defend it later on rather than waiting. So there's a fast pace of improvement. If I may add one more point, is what I'm calling is unintended positive consequences of this framework. So it's my belief that it's changing the culture of the unit, where the staff are more confident to respond. So we had something called a full-fledged mock survey to prepare our organization for Accreditation Canada. So we did a double-blind study. And what that means is the unit did not know, but we compared their responses or their compliance with required organizational practices with another unit which did not have this framework. And what we are finding is that they are better than the other units. So this is the initial information. We are going to continue to study this and see how much improvement is happening here. Because I witnessed when I went to the unit, the staff is very confident. They can go out and find out safety issues and map them according to the dimensions.
The day-to-day of the huddle, one of the first things we do is I will go to Rajni, I'll go to Karen, who is the other resource nurse, who's equally as involved in the MMS because she's the leader on the other team, to pull all the numbers together. And that's about a 20-minute endeavor. So that's a part of their daily audits that they're doing. It's the conversations they're having with the nurses. One of the lead questions we ask in the huddle that the nurses will ask their patients, this is how we get the patient feedback on a day-to-day basis, is what have you seen or heard in the past 24 hours that made you feel safe or unsafe? And that question's very intentional. We lifted that off of Virginia and Wayne. We didn't come up with that on our own. We lifted that from Virginia. And I really like the question because it forces them to give you an answer. It's not, are you safe today? Because people are just going to say yes and then say, I'll see you later. But here it forces them to give us an answer. And they can give us clear examples of, okay, the nurse checked my ID bracelet today. They did positive patient identification on us, which is one of our ROPs. So we're very heavy on that. they answered the call bell right away. That's what makes me feel safe. I'm incontinent. I really wanted to go to the bathroom, so I used the call bell. So we were able to have really detailed conversations, which is why in the moment, in the huddle, about specific safety concerns, and then we're able to address them right after the meeting. So again, it's not just something that we add to the book and we'll deal with this later on. Trust, as Shaquille mentioned, is huge. So if the nurses don't feel that they can trust that the information they're giving is going to be dealt with, they're going to stop giving it. So at least I myself am very big on that. So if you give me something, you're going to get feedback. Either it's positive or negative. Everyone wants more equipment, everyone wants more staff. So if it's not feasible, they're going to be explained to why. So I think that is the day-to-day now, is we have very candid conversations sometimes, and I'm very, I advocate for that for my staff. They need to feel that they can be safe and vulnerable around the huddle. If you had to pick one moment, that is one that I am most proud of, and I see that the most change is happening is when nurses are, rather than me pulling all this information out of people, now it's the push. They're sending it to me, which is great, and they're addressing it. And in the moment, it's not just we've had safety concerns, deal with them. It's here's the safety concerns, and here are our solutions, and this is what we think we should do. So that for me was when I knew it had taken hold, and they were doing something with it. And it wasn't me sending them off to think about things; they were doing it on their own.